Physiology, Section 7, Respiration. Chapter 1, Lung Mechanics. Okay, this is just a quick overview of the respiratory system. We're going to utilize pulmonary function tests, and we will discuss those as a key diagnostic test for the pulmonologist. Pulmonary function tests are going to consist of 3 individual tests: measurements of lung volume, airflow used to evaluate dynamic compliance using a spirometer, and alveolar membrane permeability using carbon monoxide as our marker of diffusion. That's called DLCO, diffusion lung carbon monoxide. We utilize that as a marker of overall diffusion. Okay, this is a very classic presentation of lung volumes and lung capacities. This is spirometry. We're going to have 4 lung volumes and 4 lung capacities, and we need to know all 4 lung volumes, all 4 lung capacities for step 1. And this is a very high yield graph because what it does is exhibit or show us the lung volumes and lung capacities. And I wouldn't be surprised if you had the exact same tracing on here. Again, this is spirometry. All right, how spirometry works is when we get an upward deflection, or the line goes up, this represents breathing in, which is called inspiration. It is inspiring to study respiratory physiology. I know that's corny, but I can't help myself. When the pen goes down, that's expiration. So a downward line is blowing air out, expiration. An upward line is breathing air in, inspiration. This, therefore, represents a maximal inspiratory effort, while this represents the point of a maximal expiratory effort. So again, an upward movement is inspiration. We go all the way to the top. That's a maximal inspiration. And a downward movement of the line is expiration, with the maximal shown there at the bottom. Okay, for our 4 lung volumes and 4 lung capacities, we'll start first with the one that is circled, which is tidal volume, VT, tidal volume. This is the volume of air that enters or leaves the nose or mouth per breath. So we breathe in, we breathe out, breathe in, breathe out, as you can see on the tracing. It is, again, the volume of air that enters or leaves the nose or mouth per breath. That's tidal volume. Next is inspiratory reserve volume, and these names are going to make good sense. Notice what inspiratory reserve volume is. It is the volume of air that you can take into the lungs, inspiratory reserve, starting at a normal tidal inspiration. So inspiratory reserve. So again, that volume of air I can take in to the lungs after a normal tidal inspiration, inspiratory reserve. Expiratory reserve will be just going the opposite direction. It is the volume of air you can blow out of the lungs starting after a normal tidal expiration. So expiratory reserve. What's left in the lungs is called residual volume. That's our 4th lung volume. No matter how hard you try, you don't blow all the air out of your lungs. So what's left over is residual volume. Residual. Hopefully that makes good sense. All right, the next, as we indicated, there are 4 lung volumes. Now let's talk about the 4 lung capacities. The first is a very important capacity, and this is FRC. FRC stands for functional residual capacity. Residual capacity. It is expiratory reserve plus residual volume. Notice it is the volume of air in the respiratory system after a normal tidal expiration. Again, the volume of air in the respiratory system after a normal tidal expiration. It's expiratory reserve plus residual volume. The reason FRC becomes so important is FRC is equilibrium for the respiratory system. Take away all external influences, and the respiratory system goes to FRC. And that is a key point which we will discuss and bring in several times as we go through this chapter. So FRC is equilibrium for the respiratory system. Next is inspiratory capacity. So it's inspiratory reserve plus tidal volume. It's how much air I can bring in when I start at FRC. Or in other words, how much air I can bring in after a normal tidal expiration. Again, tidal volume plus inspiratory reserve. Next, capacity is another very high yield one for step 1, as we talked about pulmonary function testing. Well, this is what we're going to utilize for pulmonary function testing, which is vital capacity. It's inspiratory reserve plus tidal volume plus expiratory reserve. So in other words, this is the volume of air I can exchange with the environment. Notice I go all the way to the top, maximal inspiration, and then I blow out until I can't blow out any more air, maximal expiration. That volume is vital capacity. Breathing is a good thing, it's vital. So this is the volume of air I can exchange with the environment, therefore it's vital capacity. Last but not least is a little tender loving care. You gotta love your lungs. Okay, not tender loving care, but total lung capacity, which is simply the sum of all 4 lung volumes. As the name implies, total lung capacity. All 4 lung volumes added together. Again, very high yield. You need to know the 4 lung volumes and the 4 lung capacities. Let's talk about ventilation. First way we can describe ventilation is minute ventilation. This is the total volume of air moved in or out of the lungs per minute. So minute ventilation, V with the subscript E, is equal to tidal volume times frequency. Now hopefully that looks very familiar from cardiovascular. You notice that's very similar to cardiac output. Cardiac output is heart rate times stroke volume. Well, minute ventilation is tidal volume, similar to stroke volume, times frequency, number of breaths per minute versus number of beats per minute. So very similar kind of idea. Normal, what we call textbook resting values, tidal volume will be about 500 mils. Breathing frequency or respiratory rate is about 15. Therefore, we have a minute ventilation of 7.5 liters per minute. Again, volume of air moved in or out of the lungs per minute. Now, this is not the important ventilation. The important ventilation we'll get to on the next slide. But this is how we calculate a minute ventilation. The reason minute ventilation is not the important ventilation is, let's stop and think about what the respiratory system does. The job of the respiratory system is to breathe air in, specifically oxygen, bring oxygen into the lungs and exchange it with the blood. This exchange occurs in alveoli, or small air sacs. That's where we get gas exchange. It also takes CO2 from the blood, put it in the alveolus, and then we blow it off. So the respiratory system, the job of the lungs is bring the good air in, blow the bad air out. But we do have to exchange it, and exchange only occurs in alveoli. Now, minute ventilation is that total volume going in and out of the respiratory system, but not all of that's involved in gas exchange. And that's because we have what's called dead space. All right, dead space are airway regions that contain air, or parts of the respiratory system that contain air, but we don't get gas exchange. In other words, they don't have alveoli. One form of dead space is anatomic dead space. And as the name implies, anatomic dead space is anatomically defined. This is what we often call the conducting zone. So from terminal bronchioles all the way up to the trachea, the pharynx, the larynx, the mouth, everything. That represents anatomic dead space. The gas exchange takes place in alveoli. So the anatomic dead space will not have alveoli. Effectively, anatomic dead space represents the tubes that connect your alveoli to atmosphere. Our alveoli are down inside the chest, but they have to communicate with atmosphere, and they do that through the tubes, the conducting zone, which is anatomic dead space. The anatomic dead space varies from individual to individual because it's influenced by body size, and it's pretty close to about 1 mil per pound. So a 150-pound individual has an anatomic dead space of about 150 mils. And we'll use that 150 as our classic textbook number for dead space. Remember, everybody has dead space. It's anatomically defined. All right, this slide illustrates the idea of the conducting zone or dead space, and then our respiratory zone, which will include alveoli. And remember, respiratory has a lot of abbreviations. P stands for pressure, capital A stands for alveoli. Okay, so a P capital AO2 represents alveolar PO2. And a nice classic textbook number of alveolar PO2 is 100. For alveolar CO2, it's going to run about 40. So we're going to say that the normal alveolar PO2 is about 100 and alveolar PCO2 is about 40. And one of the ways they're going to assess you on this is knowing what the gas composition is in the anatomic dead space at different points in the inspiratory-expiratory cycle. We'll start first with the end of expiration. Notice that the dead space here is going to have the same composition as what's in the alveoli or the respiratory zone. Then if we think about it, hopefully it makes good sense. When you make an expiratory effort, you blow air out, that anatomic dead space is going to be filled with the source. And the source here is the alveoli. So in this example, the anatomic dead space will have a PO2 of 100 and a PCO2 of about 40. The reason this becomes so important for USMLE Step 1 and clinically is we can measure these gases at the mouth. These are called end-tidal gases. So at the end of expiration, that's the end of a tidal expiration, the anatomic dead space will contain gas that has the same partial pressures of oxygen and carbon dioxide as what's in the alveolus. So in other words, a shorthand way of saying that, end-tidal gases are alveolar gases. So when I measure this at the mouth, at the end of expiration, the PO2 will be 100, PCO2 will be 40. Now another high yield point. PCO2 here is 40. This alveolar CO2 of 40 will be the same as the arterial PCO2. Notice the abbreviation, P for pressure, small a for arterial. So a big point, end tidal PCO2 is alveolar PCO2, and arterial PCO2 will be the same. So alveolar is 40, end tidal is 40, arterial is 40. That's why we monitor end tidal PCO2, because it gives us an idea, a good idea of exactly what arterial PCO2 is. Again, that's in the normal lung. All right, going the other direction, we have to think about what's in the anatomic dead space at the end of inspiration. We'll think of what the source is. The source is what we're breathing in, and atmospheric air is what we typically breathe in. So at the end of inspiration, the gases in anatomic dead space will be the same as inspired gases. Now, if we are breathing room air, don't forget that we humidify it to 100% humidity. So the PO2 will be approximately 150 millimeters of mercury, and PCO2 will be 0. Remember, there is no CO2 in atmospheric air. We know that that's not technically correct, but from the standpoint of physiology, from the standpoint of clinical medicine, we consider it 0. It is so small that it is negligible. So again, at the end of inspiration, the anatomic dead space is filled with whatever you're breathing. If it's room air, PO2 will be about 150, PCO2 will be 0, which means since there's no CO2 in atmospheric air, all CO2 in the lungs comes from blood flow. All CO2 in the lung comes from blood flow. The second type of dead space is called alveolar dead space. This refers to alveoli that have air, but they don't have blood flow. So it's ventilated, but it's not perfused. Let's think. What do you think happens to CO2 in alveolar dead space? Okay? Yeah, there's no CO2. Very good. All CO2 in the lung comes from blood flow. If I have alveoli that are not getting blood flow, pulmonary embolism for example, then there'll be no CO2 in those alveoli. They are ventilated but not perfused. Alveolar dead space. So again, the example is a pulmonary embolus. Third type of dead space is called physiologic dead space, which is simply the sum of the anatomic dead space and alveolar dead space. So in other words, it's the total dead space in the system. Now, normally we don't have alveolar dead space, so anatomic and physiologic are the same. However, when physiologic dead space is greater than anatomic dead space, that's telling us we have a lot of alveolar dead space. And again, alveolar dead space is not normal. We should have a physiologic and an anatomic that are the same. If physiologic is becoming greater than anatomic, then that means we have alveolar dead space. Okay, so given that we all have a dead space, at least an anatomic dead space, we need to take that into consideration when we calculate alveolar ventilation. This is the flow of air in and out of the alveoli per minute. So this is the crucial ventilation. I must ventilate alveoli in order to maintain homeostasis. I've got to get the oxygen to the alveoli, and I must get the CO2 out of the alveoli. So V dot A, alveolar ventilation, is tidal volume minus the dead space times the frequency. So if we use that same tidal volume that we did before, remember we had 7.5 liter minute ventilation. So we use the same tidal volume, but we subtract out a classic textbook anatomic dead space of 150 mils. Notice that alveolar ventilation is not the same as minute ventilation. We only have about 5.25 liters per minute for alveolar ventilation when we subtract out the dead space. Classic examples of long dead space or increased dead space would be ventilators. Any kind of tube that you have to breathe through is going to add dead space to the system. And that's something that we have to recognize. We need to change the tidal volume to deal with that elevated dead space, or possibly the frequency. But usually, increasing tidal volume is more effective. There are equal increases in total and alveolar ventilation per breath if I increase the tidal volume. So that's why I indicated on the previous slide the idea that we typically work with changing the tidal volumes when we have to take into account the dead space. So if I increase tidal volume, I will increase alveolar ventilation proportionally, since dead space volume is constant. For example, if the depth of breathing increases from a depth of 500 mil, what we used previously, to a depth of 700 mil, then the increase in both minute ventilation and alveolar ventilation is 200 mils per breath. We can also increase ventilation by breathing more frequently. Okay, so there is a higher increase in total ventilation per minute if I increase the frequency of breathing. However, that doesn't necessarily mean there's a greater increase or the same kind of increase in alveolar ventilation. Okay, because increasing the frequency is increasing the ventilation of dead space and alveoli. For example, for every additional inspiration with a tidal volume of 500 mil, total ventilation goes up 500. But alveolar ventilation only increases 350 if we assume dead space is 150. The idea of this is just to solidify the idea that increasing tidal volume is typically a better choice if I want to increase alveolar ventilation, because just increasing frequency is not increasing minute ventilation and alveolar ventilation to the same degree. Let's utilize some numbers to give it an example. So we have person A, person B. Person A has a tidal volume of 600 and a rate of 10. Therefore, they have a minute ventilation of 6 liters per minute. Person B also has 6 liters per minute ventilation, but they have half the tidal volume and twice the rate. The question becomes, are their alveolar ventilations the same? If you said no and guessed right away that the tidal volume is going to have a greater one, absolutely. Let's go ahead and calculate it. Person A will have a greater alveolar ventilation. Let's assume that dead space is equal to 150 in both. Person A therefore has an alveolar ventilation of 4.5 liters per minute. That's 600 minus the 150 times 10. That's the alveolar ventilation. But notice now when we calculate person B's alveolar ventilation. Tidal volume is 300, subtract out the 150, multiply times 20, and we only get 3 liters per minute. So as you can see, in general, increasing depth is more effective at increasing alveolar ventilation than increasing the frequency. Okay, now let's talk about the muscles of respiration. For inspiration, the major muscle is the diaphragm, but you also use the external intercostal muscles. When I contract the diaphragm or the external intercostals in order to breathe air in, I'm going to take the rib cage and pull it up and out. I'm going to pull it up and out. For expiration, expiration is a passive process, particularly if you're breathing quietly, which is what eupnic breathing means, just means quiet breathing. So you don't need any muscular work. You just stop the contraction of the diaphragm and external intercostals, and the system will return back to, if we can remember from an earlier slide, where? Excellent. FRC. I think I heard you say FRC. That's equilibrium for the respiratory system. Take away all external influences, your respiratory system goes to FRC. And so expiration is a passive process. We'll just return back to FRC. So all we had to do was relax the muscles of inspiration, and elastic recoil will return us to FRC. Now, we also know that we can force air out. In fact, I'm making what are called forced expirations right now as I speak. In order to force air out, we contract the abdominal muscles and the internal intercostals. There are some other muscles that are involved in that as well. But bottom line, when we contract these muscles, we're going to force air out. This is called a forced expiration. When we contract these muscles, we're going to take the chest and push it down and in. So for inspiration, we're going to pull the chest up and out. And for forced expiration, we're going to compress the chest down and in. So those are our muscles associated with ventilation. Notice all of these are skeletal muscle, and that becomes an important thing to always remember when we're talking about the respiratory system. All muscles involved in moving air are skeletal muscle. All right, now let's talk about the forces acting on the respiratory system. Units of pressure, just as a quick reminder, often used in respiratory physiology and in clinical medicine, is centimeters of water. Now, 1 centimeter of water is about 3/4 of a millimeter of mercury. It's not crucial to be able to calculate this difference. We just want to remind you that if we're going to be talking about centimeters of water, which is actually less than millimeters of mercury. All right, the key forces related to the respiratory system. Number 1, lung recoil. Lung recoil. This represents the inward force created by the elastic properties of the alveoli, which will include surface tension. So you have to think of the lungs as always trying to recoil inward, always trying to recoil inward. Think about a balloon. You put some air in a balloon, what's it trying to do? Expel the air. Well, that's exactly what your alveoli are doing. Now, here's an important point. Let's think about blowing up that balloon. Once I get a little air in the balloon, then it's easy to blow up. Now, the more air I put in it, though, the greater and greater the recoil force, and the more difficult it becomes to push the air in. So as the lungs expand, recoil increases. Think of that balloon. The more air I put into that balloon, the more it's trying to recoil back. So as lung volumes go up, recoil goes up. As lung volume goes down, recoil goes down. This recoil force is acting to collapse the lung. Now, let's back up and let's talk about a different word. Let's say compliance. Remember that compliance and elasticity are inversely related. Well, inward recoil of the lung represents elasticity. So you could call it elastic recoil, but most of the time people just call it recoil. So recoil is elasticity. Now let's go back to that second bullet point and say, okay, as the lungs expand, so as volume goes up, as lung volume goes up, recoil goes up. Well, that means elasticity is increasing. So as lung volume goes up, what happens to compliance? Excellent. Compliance is going down. Compliance is going down. Because if recoil, elasticity is increasing, that means compliance is decreasing. So at high lung volumes, we have high elastic recoil and low compliance. Now, as the lung volume goes down, there's less and less recoil, which means it's more compliant. So at low lung volumes, we have low elastic recoil and high compliance. And that's a very, very important construct for the mechanics of breathing. We will mention it again, but please try to get this down as we think our way through the mechanics of breathing. That is one of the big keys. If we can get that idea of compliance and elasticity and be able to use either term whenever we need to, that's very, very powerful. That's very, very important for owning mechanics of breathing. The second force is the chest wall. And this one's kind of hard to visualize, but just imagine that your chest wall is constantly pulling out. All right? It is springing out. There is a chest wall recoil. The chest wall wants to go out. Now, it's stuck to the lungs, right, by the pleura. So the lungs are pulling in, and the chest wall is pulling out. FRC represents the point where this outward pull of the chest is counterbalanced by the inward recoil force of the lung. Think about a tug-of-war. It's like a tug-of-war. Chest is pulling outward, lungs are pulling inward. And we hit a stalemate point where nothing is moving. Chest is pulling out as best it can, lungs are pulling in, we have counterbalanced the force, and we're stuck. Nothing's moving. In a tug-of-war, the rope is not moving. That represents FRC. Notice what determines FRC. It is determined by the outward recoil of the chest, balanced by the inward recoil of the lungs, or offset by the inward recoil of the lung. That's what creates FRC. Breathing in itself doesn't affect FRC. It's the properties, it's the recoil forces that determine FRC. So you can immediately think pathologically, if I change the recoil force of any of these, then that's going to change FRC. More on that when we get to pulmonary function testing. Next is the idea of interpleural pressure, IPP, interpleural pressure. As we indicated on the previous slide, and as you remember from your anatomy, the chest wall and the lungs are lined. They're stuck to the pleura, which is a sheet of cells that is folded back on itself, and this is a fluid-filled space. Okay? between the visceral pleura that's stuck to the lung and the parietal pleura that's stuck to the chest wall. All right, now the chest is pulling out and the lungs are pulling in. So that space is being pulled, so to speak. We're tugging on it inwardly and tugging on it outwardly. This creates a subatmospheric or negative interpleural pressure. We consider atmospheric pressure to be 0 because it's pretty constant if you're at a given location. Obviously, if you go up on a mountain, then it's changing. But in a given location, it's pretty constant. And we don't want to work with 760 millimeters of mercury. That's a big number. So we're going to consider it 0, atmospheric pressure to be 0. Well, interpleural pressure, therefore, is subatmospheric, which means it's negative since we consider atmosphere to be 0. Now, a big point about interpleural pressure, IPP, interpleural pressure, is that it represents the outside pressure for all the structures inside the chest wall. All right? IPP is the outside pressure for all the structures inside the chest. So, why do we care about outside pressure? Well, that's the next slide. Next, big concept that if you will work hard to get down and utilize and work with, will help you immensely on the mechanics of breathing. And that is the transmural pressure gradient. Well, let's think first, what does transmural mean? If you said transmural means across the wall, then you're absolutely right. Like a transmural infarct goes all the way across the wall of the ventricle. So this is going to be the same idea, across the wall, transmural pressure gradient. It is the pressure gradient across the wall. It is equal to the inside pressure minus the outside pressure. Let's just take a very basic diagram. Okay, got a little circle down there. That could be an alveolus, could be a blood vessel, could be a small airway. Doesn't matter. We have a pressure inside and we have a pressure outside. The transmural pressure gradient, if it's inside minus outside, all it's telling us is the pressure difference across the wall. That's it. So I take the inside minus the outside. Now, let's think about this. If it's a positive, if calculating the transmural pressure gradient turns out to be positive, that would mean inside pressure is greater than outside. So the transmural pressure gradient is that force pushing out against the walls of the structure. Now, if we don't have a lot of structural integrity like an alveolus, if it's a force pushing out, then the alveolus is going to be opened and expanding. The greater the force, the greater the alveolus expands, or the blood vessel. Hopefully that makes sense. So, if we have a positive transmural pressure gradient, it is effectively a force pushing out, just like as was indicated in the arrow. Now, if the transmural pressure gradient becomes negative, that means outside pressure is greater than inside. Outside is greater than inside. So now the force direction reverses. Notice how the arrow is going inward. And if I have no transmural pressure gradient, or more importantly, a negative transmural pressure gradient, that's a net force pushing inward. And collapsible tubes may collapse. They could collapse even if it's 0, depending upon their forces, i.e. alveoli, which have that inward recoil force. So structures that don't have a lot of integrity, like veins, alveoli, small airways, if I get a negative transmural pressure gradient, then there's a great tendency for them to collapse. And all that means is outside pressure is greater than inside. And again, interpleural pressure is the outside pressure for everything inside the chest. At FRC, remember that interpleural pressure is negative. So, since I have a negative interpleural pressure, that means I'm going to have a positive transmural pressure gradient. So I have a force pushing out, and that keeps alveoli open. So at rest, because IPP is negative, notice that the arrow flipped. We have a force pushing out. This outward force prevents the alveoli from collapsing. In collapsed alveoli, the term is atelectasis. So think of our balloon. Again, the balloon wants to be collapsed. There's that inward force at all times. But because I have a positive transmural pressure gradient, it can't collapse. There's a force pushing out on it. Therefore, it can't collapse. Now, transmural pressure gradient is very generic, can apply to anything, an alveolus, a blood vessel, small airway, the pipes in your house, whatever. A term that's often used with respect to the lungs and clinically is transpulmonary pressure. And transpulmonary pressure is simply the transmural pressure gradient across the whole lung. So if you're familiar with the term transpulmonary, well, then you know what transmural means because they're the same. It's just one's more specific. It's applying directly to the lung. Okay, so now we're going to start breathing. Now we're going to apply a basic understanding of those forces we discussed. Here's recoil. Lungs have an inward recoil. Notice the arrow is pointing inward. That's lung elastic recoil or elasticity. Chest is trying to pull out. So the lungs are pulling in, the chest pulls out. Where those two forces balance or counterbalance one another or offset one another, that creates FRC. This outward pull of the chest and inward pull of the lungs creates a negative, in other words, subatmospheric interpleural pressure. So notice here that interpleural pressure is -5. Now, in order to get air to move, we have to have a pressure gradient. At FRC, alveolar pressure equals atmospheric pressure. They're the same. So no air is flowing. They're both 0. So I have a 0 alveolar pressure and a -5 interpleural pressure. What's the transmural pressure gradient? If you said 5, excellent. 0 minus -5 is 5. So that's our positive transmural pressure gradient at rest, and it is positive. It is pushing the alveoli out, preventing their collapse because interpleural pressure is subatmospheric or negative. So those are our basic forces at rest, in other words, at FRC. Okay, so now let's breathe in. We know the direction of the forces, etc. Now what we're going to do is we're going to contract skeletal muscle and pull the chest up and out. By pulling the chest up and out, interpleural pressure becomes more negative. So notice it becomes less. So it may go from, say, -5 to -8. Because the interpleural pressure became more negative, I now have a greater transmural pressure gradient. So if transmural pressure gradient is going up, just think about it. What happens to the alveoli? Exactly. They distend out. They expand. And Boyle's law says when we have these two compartments, the product of pressure and volume is constant. So because the alveoli are expanding, volume goes up, therefore pressure goes down. I now have a pressure gradient for air to flow. Notice atmospheric is 0. Alveolar pressure is now subatmospheric. Let's say it's -1. Just using that as an example. Now we have a pressure gradient. Air will flow in. And that's how we get air in. And that's why this is called negative pressure breathing. Because you're making alveolar pressure subatmospheric or negative. So that's how we bring air into the lungs. And again, we're just applying our basic concepts. We're working with the idea of the recoil forces and the transmural pressure gradient. All right, now we're at the end of inspiration. Again, we made interpleural pressure more negative. Let's say it went to -8. Okay, let's say it went to -8. That's just a reasonable number to work with. Notice that the transmural pressure gradient is 8. The alveoli are distended, but the air has rushed in, and now we have an alveolar pressure that's the same as atmospheric pressure. So that air coming in equalize the pressures, and we no longer have any airflow. So notice at the end of inspiration, we have a greater transmural pressure gradient. The alveoli are more distended. They have more volume. And that volume, we got air coming in, which in turn equalized the pressures. So that's what's happening at the end of inspiration.